for our face-to-face Future Pediatrics CME program, which this year we have teed up for Tuesday and Wednesday, June 9 and 10, at the Marriott North Bethesda. And we'll be sending you information and agendas in the next couple months. But put that on your calendars for Practical Pediatrics CME. Just to let you know, these web CME programs are accredited for 1 hour of CME credit through GWU. We will send you an online link to your registration email address so that you can do your online CME link and activity code and get credit and print out your certificate. And if you're viewing this as a recorded webinar, click on the archive page below View Presentation and click on CME Instructions, and it will guide you on how to get your online CME credit. So with that, I'm thrilled to move the presentation to Larry D'Angelo and Aaron Burgess, who are going to introduce this month's topic.
Thanks, Mark. Yep. Thanks, Mark. I really appreciate it. This is Larry D'Angelo. Hi. I know many of you, obviously. I'm the chief of the Division of Adolescent and Young Adult Medicine here at Children's. And I'm here today with Aaron Burgess. Aaron's our project coordinator for our grant that we've received from the Washington AIDS Partnership to help us educate providers, both here at Children's and in the community, about important LGBTQ health issues. Neither Aaron nor I have anything to disclose to you today. Aaron, you want to go through our objectives for the day?
All right. Thank you, Dr. D'Angelo. It's great to be here today. For our objectives, upon completion of this training, this presentation, participants will be able to summarize at least 5 key concepts related to sexual orientation, gender identity/expression through case example and discussion. We'll be able to analyze 4 key issues of clinical health disparities that exist for LGBTQ children, youth, and young adults. Finally, we'll identify and apply 3 key intervention strategies that can help us as providers balance personal belief with the needs of children and professional responsibilities into examples for our own practice.
Yeah, well, needless to say, we have a big agenda ahead of you than all of you out there, and you know, we promise not to make cold calls and ask you questions, but we do want you to stay with us and hopefully enjoy the next hour. There we go. Well, why are we talking to you today? Well, pediatric primary care providers play an absolutely crucial role and also in a transformational role in providing care to sexual and minority youth. You know, if you can picture your usual office day, you are seeing patients who, you know, your teenage patients that you're seeing, your latency AIDS patients that you're seeing are often kids that have grown up in your office. You are one of the most trusted individuals in their lives, and you very well may be the first person to whom they disclose their concerns, and particularly their concerns with regard to their sexual identity. You know, the AAP has been out in front of this for a long time. 2004 was their first very strong policy statement, where they articulated that the pediatrician's office should be teen-friendly and also welcoming to sexual minority youth. They further emphasized that in their 2013 policy statement, echoing the comprehensive report published in 2011 by the Institute of Medicine, and most recently by a 2014 report by the American Association of Medical Colleges. So you can see that many of our prominent medical groups now are taking and articulating the fact that LGBTQ youth need our enhanced concern in terms of being able to provide appropriate care to them. Our agenda for today, we're going to start with a case study. We're going to talk about some background information that's very important. Aaron's going to go through a series of very important definitions for us so that we can all have a common understanding of what we're talking about. We'll discuss briefly some clinical issues and how an individual's sexual identity may influence the clinical care they receive. And then we're going to talk about some practical implications for your practices, because we know, obviously, that's the most important aspect of what we're talking about today. So, Aaron, can you give us the case example that we're focusing on today?
Sure, and I pulled today's case example from the Association of American Medical Colleges. It's entitled Gender Dysphoria in an Adolescent. Jamie is a 14-year-old adolescent who was born with anatomy consistent with the male sex, whom you have been treating since he was a young child. You ask one of the clinical assistants to take his vital signs during a well child visit. She reads your chart, including some background information, and learns that as a child, Jamie, quote, always liked girl things and felt like a girl inside, but did not think it was possible to do anything because, quote, all people with a penis must be a boy. He was rather happy and a smart child, formed peer relationships easily, played with boys and girls equally, and flexibly adapted to whatever activity was available. 2 years ago, around age of 12, at a routine visit, Jamie's mother asked if you could provide a referral for a therapist. She felt that Jamie started to become sadder for no, quote, apparent reason, and the grades in school started to slip. You sent him to a colleague who works well with depressed adolescents. Several months later, the therapist communicated to you, sounding alarmed, that Jamie mentioned in a session that he thought he was having crushes on other boys and questioned the counselor whether he might be gay. The therapist commented to you, I don't really specialize in these issues. The therapist also asked if you had performed an HIV test and STI screening despite Jamie's denial of any sexual relationships with other people. Shortly thereafter, your staff received a call from Jamie's school indicating that he had made a suicidal statement after an incident of bullying. Quote, I just don't know if I want to continue living anymore. You learned that the therapist shared with the parents that, quote, Jamie thinks he might be gay, later stating that it was okay to break the confidentiality because a safety issue was at hand. The parents repeatedly asked Jamie if he might be, quote, going through a phase for several months. However, in the years since, they have both become more supportive and have come to accept that Jamie might be gay. Your clinical assistant goes to the waiting room and looks for a teen male but cannot identify one. After calling the name Jamie, an androgynous appearing adolescent stands up wearing makeup, long pink hair, and tight-fitted jeans. The assistant acts surprised and nervously states, oh, I was expecting a young man instead, eliciting stares from other patients. During your encounter, Jamie notes that his depression has gotten worse and discloses that since he always felt so different from other boys, he concluded that he was simply gay. But this is different, he stated. It's about who I am, not who I'm attracted to. I'm old enough to realize that now. Jamie then goes on and asks you, if I'm a girl on the inside and have crushes on boys but still have a penis, does that make me gay or straight? He asks you to use female pronouns, something that close friends have already been doing, and lets you know that he, now referred to as she, prefers to be called Martine, the name of a character from a movie that she likes. On a physical exam, Jamie, who we'll now refer to as Martine, is at Tanner stage 3 and becomes tearful when you examine her genital area. Martine says that she is afraid of getting taller and developing a lot of body hair, then proclaims, quote, I just wish I didn't have to feel this way. You're taken aback and you're unsure as how to respond. You're also asked to keep this a secret from her parents. She asks you many questions about blocking puberty and hormones and about whether or not it will be possible to start them without her consent.
May I have your attention, please? Sharika Smith Davis.
This case example can be used, we're using it to provide a frame of reference throughout our webinar experience. It's just representative of one of a myriad of cases that LGBTQ patients may face in your practice, and if time permits, we'll revisit at the conclusion of today's presentation.
Yeah, it's a particularly tough case and a challenging case, but we wanted to take it to an extreme so that we can share with you the concerns that we have for our patients to ensure that they're getting the best care possible in our offices. Well, you know, who are we talking about? And, you know, are you seeing in your office patients who may be LGBTQ youth? You know, we're pretty sure you are. We estimate that there are about 60,000 adolescent patients who are receiving care, you know, throughout our network. Potentially more. That's the lower estimate in terms of the total number of adolescent patients that our network serves. In terms, if you use the figure, the Gallup poll figure of 3.4% of LGBTQ self-identified individuals, that's a lower limit of about 2,000 adolescents who are self-identified as LGBTQ youth. And if you use the Kinsey figure of 10%, that's about 6,000. So there are a lot of teenagers out there that are potentially in our office as our patients who are LGBTQ self-identified. And remember that lots of our adolescent patients aren't going to self-identify as LGBTQ until probably much later on in their adult development. So, you know, we can anticipate that these youth are indeed in our offices.
Yes, there is.
I'd like to present to you for your consideration the Gender Unicorn, and it's brought to you by the Trans Student Equality Resources. It helps to give a great overview of what we're going to talk about now with our background information, talking about the LGBTQ population, sexuality, gender identity, and expression, and so on. First of all, we'll talk about gender identity and gender expression / presentation. I believe the Gender Unicorn does a great job of breaking down gender into identity and expression, further extrapolating it from sex. It's important to note on our slide here that the information shown is on our own fluid continuum. So basically, we'll start with the fundament of sex, an identification of reproductive organs and biology from birth, including gonads, chromosomes, external gender organs, secondary sex characteristics, hormonal balance, etc. Common terms used being male and female. Sex is represented on our image by the chromosome symbol, and you'll note that it includes other / intersex, so we can talk about variance and differences. Gender, the socially ascribed roles based upon the individual's biological sex, which we can think of as a daily living and presentation. Common terms for gender can be man and woman. Gender identity is represented on the image as the rainbow symbol in the thought bubble. Now this can be on a continuum of man, woman, or something different. Gender expression, you'll note, is represented by the green dots. This shows the outside expression of the unicorn, so this is their outward presentation that other people see. I'd like to make a quick note when we're talking about man and woman, male, female, that's representative of a gender binary. It's this idea that we have that there are only two genders, male, female, man, woman, and that a person must be strictly gendered as either or. The Gender Unicorn is helping us look past that, and on our next slide, you'll see some key gender terminology. Now, I'm going to be presenting a lot of different terms today, and it's important to not get tripped up on every single term that you see. I'm presenting with a lot of information so we can have a background. We've already went into a discussion of sex versus gender, and as a provider, you may have seen words like transgender, transsexual in your day-to-day practice, but you might not have seen the word cisgender. In order to understand trans-related issues, we have to have something that we can compare it against. So cisgender is a person whose sex and their gender match the societal expectations and are congruent, i.e. born female, living daily presentation as a woman. Transgender is used as this broad umbrella term to describe people who transcend or transform expectations of gender norms through identity, expression, or role. We use words like transcend or transform because we're not associating value with that. We're strictly pointing out differences. For the purposes of our presentation today, we're going to focus on one area of the transgender spectrum, which is the term transsexual. This term, some consider this term to be outdated, but in the medical community, I think it's important to be able to have identifiers. This identifier is an individual assigned one gender at birth who now can identify and live as what most people would consider the, quote, opposite gender. Now, this may or may not use hormones or surgical procedures to bring their bodies, voices, and other physical cues more in line with cultural expectations for the gender in which they're living. Now, you may hear these words such as transgender, male to female, female to male, MTF, FTM, etc. When we speak about gender variance, I will briefly note that intersex is used for a variety of conditions in which a person is born with reproductive or sexual anatomy that doesn't seem to fit typical definitions of female or male, and this may or may not show up at birth. This may show later in physical development. These terms, it's important to note, are influenced by, we think of these terms in relation to our own cultural backgrounds and experiences. For instance, you'll see the word two-spirit. Native persons use this term for people who have attributes of both genders, have distinct gender social roles, accepted roles in their tribe, active roles in their tribe, and are often involved in mystical, spiritual rituals such as shamans. Now, their dress is usually a mix of male and female articles, and they are seen as a separate or third gender. I'll take a quick moment and speak about gender development. When we talk a lot about LGBTQ issues, Dr. D'Angelo, we talk about adolescence, but it's important to think of the broader lifespan in pediatrics. When discussing gender development, it's important to understand the critical nature of gender variance. This is when a person, either by nature or choice, does not conform to gender-based expectations of our society. Gender variance is seen in children as early as before 3 years old. This is appropriate developmental time for children to learn their gender roles and expectations and how these roles relate to themselves. The presence of gender-varying behavior in a child is not necessarily a determinant for clinical issues with gender or sexual orientation later, again, pointing out the normal and healthy developmental milestones and behavior. A final note is psychosocial and developmental education and intervention needs to be in place for parents as well as their gender-variant child to address these complex dynamics if requested by the patient or family. That was a brief discussion of gender.
All right, and I see we have the gender unicorn back.
We have another visit from our friend the unicorn. Now we're going to go ahead and talk about sexuality and sexual orientation, about how we relate to other people. Sexuality can be broken down into 3 components. We have identity, attraction, and behavior. I'm pointing this out because we can note that behavior, including sex act, is just one component of sexuality. This is critical when we think of HIV and STI care and we discuss MSM, or men having sex with men, behavior as a risk factor. We must remember that behavior does not necessarily equal or fall in line with a person's identity. Although all 3 are on a spectrum, they can run in different directions, these terms that we're going to talk about. Sexual attraction is represented by the orange heart. It can fall on the continuum for women, for men, for other genders, for multiple, at varying degrees of intensity, and can run in different directions. We're separating sexual attraction from romantic and emotional attraction. You can see romantic and emotional attraction represented in red, and they can also run in different multiple directions separate from the attraction behavior.
You know, Aaron, that's very interesting because so often in our office, particularly with our younger adolescents, they feel particularly uninhibited in telling us, even though they are not sexually active, they aren't even considering having sex. When we ask them who you're attracted to, men, women, or both, I would say anywhere between 25 and 50% of the time, they answer both. Because I think that it is indeed on a continuum, and it's part of the developmental spectrum.
It's important to note also that not every person is going to experience or identify with all three of these areas too. On our next slide, we have some more key terminology. And some of the terms on this slide we may have seen before as well. Lesbian and gay. Lesbian used to describe female-identified people attracted romantically, erotically, and or emotionally attracted to other female-identified people. So you can see it's more than just sex and sex acts. Gay is used more to describe male people. Female people may also use that word. Bisexual when we think of bisexual, we think of the binary of people whose affection and or orientation goes toward both men and women to some degree. And back when we talked about two-spirit, we included cultural influence. In a similar way, we can think of same-gender loving as a term used by Black African American community that identifies women who love women and men who love men, but this resonates with the uniqueness of Black culture and life. Lesbian, gay, bisexual are considered words used by dominant culture, by white culture, is superimposed onto other people. Terms like same-gender loving are important because they take into the unique cultural experiences of different people. You may hear words in your practice such as queer and pansexual. Queer is a reclaimed word. So this word was formerly used solely as a slur, but has been semantically overturned by members of the group. So this is umbrella term which embraces a matrix of preferences, orientations, genders, habits. If we think of the binary as black and white, we can think of the identification of queer as the shades of gray. I've done these types of trainings for a long time, and I've been asked by providers, I don't feel comfortable referring to my patients as a queer. Well, if you use the term, if you refer to them as a queer, that comes across as very negative and derogatory. Your patient comes to you and openly identifies with queer as queer, then I believe that that's very appropriate for you to ask them questions and to be able to explore that with them.
Yeah, in fact, I mean, it's certainly on the spectrum of words that adolescents often use to describe themselves, and particularly true in some minority groups. They own that. That's their word. That's a self-identification. But I think you're absolutely right. I don't think any of us feel comfortable going there and using those terms. It's quite clear that we can hear them self-describe themselves in that way.
Right. It's important when we think of, and this surpasses LGBTQ issues, we want to get with the patient where they're at. We want to use the language that they use, and this is a good example of putting aside our personal values and getting with them where they're at. Pansexual is another word you might hear. If we thought of bisexual as a binary for men and women, we can think of pansexual with the prefix pan used to describe a person who's attracted to all or many gender expressions surpassing that binary. Finally, asexual used to describe a person who may not have significant sexual attraction in one particular gender area or the absence of sexual attraction altogether. We'll talk a moment about development and coming out. The coming out process, it's important to note, is process-oriented. We speak of it as a process. It's not a one-time experience. It crosses all systems from different system levels, family, community, different relationships. First, we got to understand a few terms for this process. You might have heard of a patient being, quote, in the closet. This refers to when an LGBTQ person has not accepted their own sexuality, gender identity, or physical makeup. It also can include people who have accepted their own identity, but they haven't determined a safe space in which to disclose that. So it doesn't necessarily mean that they haven't accepted it. It's all about that safe space. The coming out itself refers to the process by which one accepts their own identity, and then it refers to the process of where they share that identity with others. This is a continual, lifelong process for LGBTQ individuals. The appropriate development is related to the reception that they receive during the coming out experience. I believe that it makes sense that if a youth going through this identity development receives appropriate and positive support and feedback, that will push them further along appropriate development. If they receive negative feedback or negative experiences, it may inhibit or deter their experience and their identity.
Yeah, and I think it's so interesting because, you know, what we see for many of our youth is that, you know, this is not just a one-time occurrence. That certainly they may feel comfortable coming out in one setting, but not be able to come out in another setting, or feel comfortable coming out in another setting. And the reason I mention this is that one of the settings where often youth will feel comfortable coming out is in a healthcare provider's office. And again, I want to reemphasize the fact that primary care providers may be the very first people who learn about the struggles that youth are having with their sexual identity. Well, Aaron, share with me your thoughts. I mean, you know, this is a professional area that you've been involved with for some time. Now, share with me your thoughts. Why might a youth feel uncomfortable about disclosing their sexual orientation or their gender identity?
That's a great question. I have a few responses, quick responses I would like to make to that. Youth might feel uncomfortable for many reasons. Like we spoke about earlier, they might, if they have had previous negative experiences, this will make them less likely to feel comfortable disclosing to you. At the same time, we're making a broad assumption that the youth that you're seeing in your office know exactly who they are and are at a further point in their identity development and acceptance, and have synthesized that into their overall identity. They might be questioning. They might be unsure. When we talk about LGBTQ, the Q is both for queer, but also for questioning. So they might not be able to answer these questions or articulate it clearly that you ask them. And finally, something very important that I believe that if you've been this child's provider for a while or for perhaps their entire life, they might be afraid of disappointing you in terms of their evolving identification.
Yeah. Yeah, no, I think you're absolutely right. Well, a particularly tough issue, and that providers face, certainly in our case example earlier, Jamie's providers faced, what were they going to tell Jamie's parents? And, I think that all of us live in jurisdictions now where we know that with regard to sexual issues, with regard to depression, with regard to pregnancy, that we are able to provide confidential health care. Where does this fall in terms of the range there? And, do we have a right or even an obligation to disclose our patients' identities to others, particularly their parents? I think that question hangs out there. Mm-hmm. I would hope that if we do so with a little bit more thoughtfulness than the example of the counselor mm-hmm. Who disclosed Jamie's struggles to Jamie's parents.
Right. Right. When we think of that disclosure, there are many different people that disclosure could go to. Examples in previous discussions that I've facilitated: doctors, nurses, social workers, therapists, parent, clergy members.
All right, well, you know, what I want to discuss for a moment is not the specific clinical issues, but rather at least how the clinical issues that we're going to be encountering are influenced and overlaid by the struggles that youth are going through with regard to their sexual identity. So take me through some of the risk factors that are going to impact on LGBTQ youth.
Sure. The Institute of Medicine has identified several risk factors you can see on the screen, including harassment, victimization, violence, substance abuse, issues of homelessness, and issues of childhood abuse. If we think of risk factors, we also need to take into consideration protective factors. In the absence of the various levels of protective factors like family and support networks, individually, interactionally, broader system, and LGBTQ youth may not develop appropriate resiliency and positive coping mechanisms, making them at risk for these areas that we see. A strong contributor to these risk factors is stigma. Stigma impacts youth on a personal and structural level and contributes to barriers to accessing healthcare. There's different types of personal stigma: enacted stigma, felt stigma, internalized stigma, but there's also the structural stigma that we need to take into consideration. Provider knowledge versus provider values, for example. Health insurance and health care accessibility as another example, et cetera.
Yeah. So stigma sort of presents itself then as a sum total of many negative attitudes that these youth are going to be feeling.
Yes, yes. It's important to note that not every LGBTQ youth may experience these types of risk factors and experience this type of stigma, but we can't talk about these issues without referring to the strong contributor the stigma has to it.
Yeah. Well, I want to take a moment just to mention some of the pitfalls of caring for these patients in terms of the clinical encounters. And first of all, you know, I have to remind us that, you know, in caring for these patients, it's not all about the kinds of sexual contact they're having with others. You know, Aaron brought to my attention a couple months ago an interesting case of a young man who was out to his provider. His provider wasn't very supportive and had given him a significant degree of negative feedback with regard to his declaration of his sexual identity. He went to him with complaints of some right inguinal and right lower quadrant pain, and the provider was sure that he had a sexually transmitted disease without even appropriate testing, went ahead and treated him for gonorrhea and chlamydia. A couple days later, the patient came back to the office, still complaining, pain getting worse. And of course, the end of the story is that 4 or 5 days later, he ended up in the emergency room with a rigid abdomen, having experienced a ruptured appendix over that time. And, you know, maybe it's just a kind of diagnosis that people can miss, and maybe it was more subtle than we're giving the provider credit for. But I can't help but think, when you told me that story, Aaron, that you know, how heavily influenced that provider was by the fact that he knew the individual's sexual identity. Secondly, you know, I have to remind us that during adolescence, sexual partner preference may evolve. You know, we often encounter in our office young men or young women who've had sex primarily with opposite gender partners who, over the course of a year or two, have evolved in terms of their sexual identity and now are having sex with only individuals of the same gender. And that leads to myths. And myths like the fact that gay and lesbian youth don't have sexual contact with members of the opposite gender. They do indeed. And in fact, many non-straight men, and particularly women, do. And providers feel inappropriately, particularly for women, that they are at low risk of getting STIs because they aren't having sex with men, who they very well may have had sex with men and deserve the same gynecologic evaluations, physical examination, and STI testing that all sexually active teens deserve. And it's essential, regardless of the gender of their sexual partners at that time and moment that you're seeing them. I want to ask you, Aaron, that there are factors, and you certainly mentioned stigma as one of them, that indeed get in the way of health care for LGBTQ youth.
Well, if we talk about factors getting in the way, barriers, we're then going right back to stigma for a moment. If a gay and bisexual, if an LGBT youth does not feel confident speaking to his provider, he will not receive adequate care. It's important to note that in the same way that all health issues are related to sex, not all sexual issues are related to HIV. Not everything's HIV related. I very bluntly stated that on our slide today. HIV is not the broader issue. HIV is an intersection into the broader issues of LGBT disparities, and that's the shift in frame that we're trying to make. The CDC reported that incidence among young black gay men is almost 3 times likely than that of young white men aged 12 to 24. Again, these youth need to be able to come to providers, speak openly, and being able to have that safe space, which we'll talk a little bit more about later, is one major way to barriers.
Yeah, and I think the feedback that I've gotten from a number of my patients, Aaron, is that we are so focused on HIV, which is important.
Mm-hmm.
I mean, obviously we provide care to many young HIV-infected individuals here in our office. But having said that, they don't want to be characterized as individuals who are inevitably going to get HIV infection, or who our evaluation of them for HIV infection so colors our clinical approach that we're overlooking other things that are very important to them.
I have a quote from a young adult male. I stopped going to the doctor for many years because I was so uncomfortable. Every time I went to the doctor for any issue, when they found out I was gay, they started asking about my sex life and made me feel like I had these crazy STDs. I felt so ashamed to even mention that I might even be sick because I was so embarrassed that all they kept thinking was I was dirty.
Okay. When we mentioned earlier on in our case example some of the particular struggles that transgender youth encounter, and certainly that was true for Jamie. I would ask you to sort of mention a few of those now for us.
Certainly. When we think about trans-specific health, there's certain areas to take into consideration: gender identity, development during puberty, negligent treatment, and quote black market experience, and that could be its own presentation. But what I would like to share with you instead, is some quotes and feedback that I have been given as a point of impact. The 3 quotes that appear on the screen were reported to have occurred within the past 12 months in our patient population. In the past 12 months in our patient population. I said that twice.
That's here in the Adolescent Health Center, and what can I say? Even in places where we would like to think of ourselves as the people least likely to do things like this, clearly it's here.
And these experiences, and I'm just going to take a moment and read them out loud. They made me feel like I was the clown in the circus. I came in for issues with my ankle and was forced to show my genitals to the doctor. The nurse demanded that I pray for forgiveness before she would treat me. When the young adults reported these to me, it was a really intense moment. There was a lot of shame and a lot of embarrassment from even having to report that to me.
Yeah. Well, I mean, it was stunning and disturbing, and in the interest of the education of all of us, we make this self-disclosure and say that I can't explain this, and I can only tell you that if we do it, I'm sure many of you do it out there inadvertently as well. Okay, Aaron, obviously for years we've been sensitized to the mental health stress and strains that LGBTQ youth encounter, and I'd like you to, if you will, sort of go over a few of these for us.
Sure. We'll talk about, first we'll make note of body image satisfaction. LGBTQ youth are more likely to have body image and eating disorder spectrum issues. Compounded pressure of identity development, coming out, and fitting in can greatly impact youth. While much research surrounds girls and eating disorders, more discussion, I believe, needs to be around boys and their unique concerns as well. Anorexia, bulimia, obesity, quote, Adonis complex, and transgender youth have particular concern as they're trying to grasp with a body impacted by puberty that does not match their inherent gender identity. You'll note on the slide, 25% of people with eating disorders are male.
What about substance abuse?
When we think about substance abuse, we have a quote of bisexual disparity of 4.42 times more likely to use or abuse substance. But what I would like to think about are some of the reasons why youth may use or abuse. And just a couple ones off the top of my head are peer pressure, coping mechanisms, and some extreme examples like for survival sex, things of that nature.
Yeah. Unfortunately, we've seen that in our practice, that youth are abusing substances and also being sexually abused at the same time.
Now, certainly, recreational use is there as well, but these are some things we need to take into consideration. The Family Acceptance Project gives us a really great visual. Levels of family rejection impact the rates of substance use and abuse. You'll note on the slide that the lower level of the rejection, the lower the risk of substance abuse and use in the youth's experience, and you can see how that grows exponentially from low to moderate to high rejection that they experience. We'll take a moment and we're going to talk about depression, and we're going to talk about it in relation to suicidality. We know that suicide is the third leading cause of death amongst 15 to 24-year-olds. Lesbian and gay youth are 4 times more likely to attempt than their straight counterparts. Bisexual youth, almost 5 times more likely. And it's a little overwhelming to me to think that 50% of transgender youth have attempted suicide. Here's a few ways that you as a provider can help a suicidal person. Let's look for verbal, both directly and indirect cues, behavioral cues, and situational clues as well. Ask as directly or indirectly as you can. So, now, there's a whole host of questions, Dr. D'Angelo, that we could ask, but I'll just give you one question to not ask. Mm-hmm. Do not ask, "You aren't suicidal, are you?" That's the one question that I would like you to not ask. Yeah. And I'm just going to, I believe it's worth mentioning quickly two types of suicide prevention methodology. If you're a provider and you're unsure of how to ask, here's 2 ways that you can think of. One is the QPR method, which is question, persuade, and refer. Question them about what's going on with them and their intent, persuade them to stay alive, and refer them to the appropriate services they need, whether that's with you or with another provider. The Trevor Project has come up with CARE, the acronym CARE. Connect the person to resources and to a supported, trusted adult. Accept and listen to the person's feelings, taking it seriously every time. Respond if a person has a plan to attempt suicide and to tell someone you trust. and empower the person to get help. They can contact us at the Children's National Medical Center. The Trevor Helpline is 1-866-488-7386. I have that at the conclusion as well, or in an emergency, of course, 911.
Okay.
You'll note levels of family rejection impacting suicide rate and attempt. This is, you can see exponentially from low up to high.
Yeah. Okay. Well, help me. You've mentioned some of the potential tools that we can use, or at least some of the questioning that we can do. Is in youth like this who are so troubled, is suicide preventable?
That's a tough question. The point of, I think, of your question is we need to think outside of this binary of yes and no, and we need to examine if and when. Here's what I think, and here's what some of the literature that has noted. If a youth receives targeted and appropriate intervention in their time of need, then their risk of completing a suicidal act may diminish or decrease. I would just like to make note that the images you see on the slide are of youth who have completed the act of suicide due to bullying and lack of support. These look just like the youth that you may see in your day-to-day practice.
Absolutely. Okay. I'd like to now turn our attention to what are some of the implications for our practices. First of all, I think, Aaron, I'd like you to sort of go over the idea that we have certainly changed our attitudes over the course of the past 50 years, and I would certainly hope that we've changed our attitudes. But there are major changes, such as this one.
You're right. Attitudes have been changing rapidly, but they still remain a barrier for LGBTQ people, particularly transgender people. And we know that attitudes have major effect on health outcomes. So in regards to pathology, historically, the medical community considered homosexuality as a term, a condition which often led to non-affirming care. That term was removed as a mental health disorder from the DSM in 1973. 2015, and there's still stigma associated with that. Currently, transgender identity is still classified as pathology by the DSM. There has been a shift from gender identity disorder to gender dysphoria. This is an emphasis on personal distress. So we can think of it as the point we're treating this person with dysphoria to help them decrease their personal distress and live freely. Provider values, I strongly state, must be mutually exclusive from a health diagnosis.
Okay. Well, where do LGBTQ youth experience heterosexism?
Well, what is heterosexism? Yeah. Heterosexism is a system of attitudes, biases, and discrimination in favor of opposite sex sexuality and relationships. It's including this presumption that other people are straight, or that opposite sexual attractions and relationships are the only norm and therefore superior. And the big answer of where do they experience this everywhere. They experience this across all system levels.
Okay, well, what do I think it takes? Obviously, for a healthcare professional to provide excellent care to LGBTQ youth. Well, first of all, I think that we need to be self-aware of our beliefs and come to terms with any of the prejudices that we may indeed have. Secondly, we must have knowledge and appreciation of LGBTQ youth and anticipate the kinds of struggles that they're undergoing. Third, we have to be competent professionally in terms of providing care. Or if we don't feel competent professionally, we at least need to know where to refer patients to get that kind of competent professional care. Fourth, we need to emphasize our professional values over our personal values if we indeed do feel any of those twinges of discrimination that we may have been raised with. And finally, we need to realize that all of these together will culminate in the ability to work well with LGBTQ youth. Privacy is a huge issue, and again, I want to remind us, particularly for teens between the ages of 13 and 17, in all of our jurisdictions, the age of 18 is majority, and therefore, obviously, we can't discuss the healthcare issues with anyone else without the express permission of the patient. However, between the ages of 13 and 17, remember contraception, pregnancy, alcohol or drug abuse, or mental or emotional health, or sexually transmitted disease and infection issues are all protected under the laws of our states. And, you know, it's never inappropriate to use the HEADS format in terms of initiating our interviews with teens. Their home environment, their education, employment, their eating activities, drugs, and finally the S standing for sexuality, suicidality, and safety. And you made reference to this earlier on in the case example of Jamie and Jamie's strong preference with regard to pronouns. But I think that we need to acknowledge that indeed LGBTQ youth may have strong preferences. Take us through that.
When we think about pronouns and when we think about how, we need to think about how the patient chooses to identify for themselves. They may use something that you see on this slide right here, or they may use something entirely different. But it's important for us to be able to acknowledge that there are these differences and get that information from them. I like this image from transstudent.org. They is grammatically correct gender-neutral pronoun. It's been used by Shakespeare, Oscar Wilde, and it's even in the dictionary. So we can see the breakdown of pronouns on the right from subject, object, possessive, reflexive, etc. So very common for she, her, hers, and herself. We know he, him, his, and himself. The, here, hears, and hearself can also be appropriate pronoun, gender-neutral pronouns.
Ooh, is that in the dictionary? Probably not yet.
We're working on that.
You're working on that. Okay. Well, you know, I think it finally comes down to, you know, earlier you made reference to safe space and to the concept of being an ally. Can you reflect a little bit more on that for me?
Sure. Let's think of an ally. An ally works to be an agent of social change rather than an agent of oppression, broadly. An ally is someone who confronts, and in the context of LGBTQ patients and working with LGBTQ youth, confronting heterosexism, homophobia, biphobia, transphobia, and of course heterosexual privilege in themselves and others out of self-interest, out of this concern for the well-being of people, and the belief that heterosexism that we've previously talked about is the social justice issue, right? How can we be an ally to our LGBTQ patients? Well, one way is to create a safe space in your practice where the youth can come and feel comfortable and protected. This can be done in a number of ways. Quite simply, the easiest way to do this, Dr. D'Angelo, is to facilitate discussion with the members of your staff. Provide this type of education to your staff as well, make sure everyone's on the same page, and just have a judgment-free space, an open, active space where these patients can be safe in being who they are. We've discussed what could be some appropriate nomenclature for providers to use to identify their practice as a safe space, and the wording that we're using today, we've We've looked at in the literature, and I've also done a poll amongst the various providers, and this seems to be common language that providers can use. This is an open and affirming practice that respects the rights and values of patients and families, regardless of gender identity and sexual orientation.
Great. That sounds simple to me. Anyway, we are reaching the end of our hour, but what I did want to do was to just sort of bring ourselves back to the case that Aaron presented a little earlier, and that's Jamie, who is the young transgender woman, and some of the struggles that she faced. And I think that in summary I can say that, we're going to encounter these patients in our practice, and that we need to make every effort to provide the highest quality level of care that we can, recognizing the societal limitations that are put on us to some degree, and certainly on our patients. Aaron, any last thoughts?
In our case of Jamie or Martine, in her example, the LGBT issues were the primary reasons for her visit. It's important to note that the primary visit may be a rupturing appendix, as we talked about earlier, but that these dynamics may be come into play in that patient's life. And if we don't act, we might miss a prime opportunity to be able to provide appropriate support and intervention.
Great. Okay. Well, I can't thank you enough, all, for being here with us today, and I thank Aaron. Not with us today is my other co-PI, and that's Mike Mancia. Mike is one of our social workers here at Children's, and I'd like to say on behalf of all three of us, obviously we are available, to your community and to your practices for these kinds of trainings and interactions that, very proudly, I know that some of you know that we are indeed starting a articulated clinic called the Youth Pride Clinic, and our first office sessions will be in mid-April for any patients who you would like to refer to us. Thanks so much, Aaron, for being here. Mark, are you there to say goodbye?
I am, Larry. So I wanted to thank you and Aaron and Mike and our audience for participating today. I want to thank you for a great overview. We will be recording this session, so if you have friends or colleagues who you think might enjoy the presentation and get CME credit by viewing it, the recorded version, you'll be able to find that within a few days on our website for CNHN. And if folks have interest in expanding on this topic for our June Future Pediatrics sessions, shoot me an email, let me know. And I want to thank you all for attending. Great session. So we will be concluding.